afternoon, everyone. Welcome to the post-lunch session of International Conference Pharmanecia 3.E on the theme Emerging Trends in Pharmaceutical Research, organized by Dr.DY Patil Institute of Pharmaceutical Sciences and Research and Dr.DY Patil Medical College, Hospital and Research Center, Pimpri, Pune, hosted by Operant Pharmacy Federation. Moving to scientific session of the conference, for the session we have with us Dr. Rajesh Ramasamy, Head of Department, Department of Pathology, Faculty of Medicine and Health Sciences and Teaching Hospital of UPM, University Putra, Malaysia. For the session, we have Chairperson Dr. V. Adepalli, Research Director, DPU Pharmacy, and Co-Chairperson Dr. S.S. Bujbal, Vice Principal, DPU Pharmacy. I request Chairperson and Co-Chairperson to take their seats. I request Chairperson to please proceed with the session. Please, sir.
A very good afternoon to all the delegates and respected speakers of these scientific sessions. It's my privilege to introduce the audience today's first speaker, Professor Dr. Rajesh Ramasamy sir, Head of the Department of Pathology, Faculty of Medicine and Health Sciences and Teaching Hospital of UPM, University Putra, Malaysia. Sir has graduated from National University of Malaysia in 2000 and pursued his PhD in stem cell transplantation and immunology at Imperial College of London, UK. Due to his keen interest in Indian traditional medicine, he also pursued and completed a course in Siddha medicine in 2012. After completing his PhD, Sir joined the Faculty of Medicine and Health Sciences, UPM, and formed Stem Cell and Immunity Research Group. Sir has worked mainly on molecular and cellular mechanism of immunomodulation produced by various human mesenchymal stem cells on different immune cells. His research areas are stem cell related in cardiovascular disease, diabetes, cancer, aging, and medicinal plant research. His phytopharmaceutical research focuses on Moringa oleifera, Cassia paniculata, Terminal chebula, exploring their impact on immune and stem cell. Additionally, in 2015, he pursued a sabbatical at King's College of London at the Regenerative Medicine Unit, where he focused on producing stem cells and unraveling the cellular crosstalk between stem cells and cancer. Sir has served on various committees at university, national and international level. He is one of the panel members of the Grant Evaluation Board at several universities, including the Ministry of Science, Technology and Innovation. He has also served as a grant evaluator at Medical Research Council, UK and Polish Science Academy. He is also a panelist at the National Ethics Committee for Cell-Based Research and Therapy at the Ministry of Health, Malaysia, to evaluate stem cell research and therapeutics. Currently, he is the Vice President of the Malaysian Society for Stem Cell Research and Therapy and a member of International Society for Stem Cell Research, International Society for Cell Therapy and Tissue Engineering and Regenerative Society of Malaysia. Dr. Rajesh Ramasamy sir is also the Editor-in-Chief of Regenerative Research, an international journal theme on regenerative medicine and tissue engineering. We are very much fortunate to have you with us, sir. Now I request sir to please proceed with his scientific session. And sir's talk, it will be for 45 minutes, and after that we'll be taking question answer session. Please welcome, sir.
Of the pharmacology research when it comes to regenerative medicines. okay? And my major aim is not the front bencher or back benchers, because you're the future scientists, the future farmers in this country. So don't shy, don't worry, be interactive, think I'm your peers, think I'm your friends. So don't think me as your lecturer, something else, right? So be with me for the next 30 minutes, and I will be much happy to share what happened in pharmacology. Because just now, someone asked me, how could, okay, pharmacology students or pharmacists can be outshine in the field? You see, the field are actually evolving and moving. Until you move to new niche area in pharmacology, you cannot be visible. So one of the weird? Fine. Okay, good. Okay, all of you can hear me, right? Okay, so I'm going to talk about how you can utilize regenerative medicines into your research or into your career. So all of you in a pharmacology pharmacist, okay? How regenerative medicine has changed the field of pharmacology. Okay, my talk will be the current research trends in regenerative medicine and herbal medicines. And first of all, this is what I'm going to talk. A very just simple one. What is all about the regenerative medicine, stem cell, how it can be used in pharmacology or pharmacy studies. And first of all, what is a regenerative medicine? So you should know what is a regenerative medicine, right? Like a stem cell. Stem cell are kind of the components in regenerative medicine. Usually what happens is we consume or employ regenerative medicine. Simply say kaya kalp. Have you gone to see your folklore, your what you call doctor in the village? No, who giving you herbs and talk about kaya kalp, right? So what I'm talking about regenerative medicine is all about kaya kalpam or kaya kalp. It's nothing alien from Indian medical culture. So I'm just rekindling, revoke what we had done previously many thousands years ago into a modern medicine. So that's all about regenerative medicines. It's just to repair, replace, and also regenerate the organ which has been damaged, which has been what you call vanished. So under the regenerative medicines, we have three components: tissue engineering, biomaterials, and stem cell therapy. So I'll be much happy to talking on stem cell. So today talk all about stem cells and the phytochemical. In between, if you have anything to ask me, feel free to ask. Don't shy, okay? When you become very quiet, I may thought you understand everything or nothing. So just give some response, right? Okay, so what is a regeneration? It's simple. Have you seen that iguana, have you seen the lizard in your house? I mean, most of the girls will scared about with the lizards, right? They don't scare their mother-in-law, they don't scare their husband, but they will scare the lizard. See what lizard does? That's why every husband very jealous of lizard, because their wife scared of the lizard, not of themselves. Right. Okay, what lizard does? Tell me, when you're young, what lizard does? Whenever lizard sees the enemy, what it does? Huh? It will drop the tail. Can you drop your hand and grow back? Then what's a being and a human being in the higher hierarchy in the mammalian? See, lizard actually drop the tail and gain tail. If I chop your hand, can you grow your hand? No. This is what we have lost during the evolutions. See, we think we become a great human being because under the transformation, but we lost many things during the evolutions. And one of them is regenerative potential, okay? Like a human being, we have a limited regeneration like a liver cell. Liver is one of the highly regenerating organs. And what else regenerating? Fat. This joke, okay? And also some like a wound healing. Whenever you have the cut in your hand, you have wound healing. So these are a symbol of regeneration that happened in the human being, okay? However, is it sufficient to treat the patient? Not. So here there is a gap between the regenerative medicine whereby we can utilize our knowledge to enhance the regeneration potential of our self. And like any kind of a study, right? Whenever you have a new subject in your class, it has to go definition. What is a stem cell? What is the difference between stem cell and other cell? Any idea? I saw some abstract on stem cell. So I assume you guys will have some minimum knowledge on stem cell. Any volunteer? If I say myself Rajesh, I'm a son of Ramasamy. That's why I'm Rajesh Ramasamy. If you define a stem cell, how do you define them? Huh? Okay. Okay, and?
Stem cell having ability of differentiate into different type of
Yeah, wonderful. I think here I found that the girls are very vertical intellectual. Okay, maybe the men are a bit in silence, but they are quite expressive. See, when someone says stem cell, the stem cell has two characteristics. One is cell renewal. They're able to cell proliferate to produce their own copies, and they're also able to differentiate into a mature cell. If it is a hematopoietic stem cell can give rise to white cell blood, red cell blood, and yeah, so that's what we call differentiation. Okay, so if a cell that what we call fulfill these two criteria, we call them as the stem cell. And where can we get a stem cell? Every part of your body, even your dormant tissue. Which tissue in your body is very dormant? Do nothing, just stay there. Sometimes the brain, sometimes it's your fat, right? Even the fat has a stem cell. So every part of your body has a stem cell, okay? From hair follicle stem cell. If you don't have hair follicle, you don't have a hair growing. Now see, think about it, you have everything. And the bone marrow have the, what you call stem cell that produce. Do you know that all our RBC will be killed every 3 months? The basic hematology. So where our body get new RBC, red blood cell, from the stem cell. So stem cell can be retrieved from that embryo, fetal tissue, and also the adult tissue. And the adult tissue is one of the topic in that regeneration. Why? Adult tissue don't have so much of ethical concern. Like an embryo, right? Embryo is one of the totipotent stem cell, right? Sorry, it's a pluripotent stem cell. However, to get the embryo from human being, you have to kill an embryo. So we have, mostly Indians are very emotional, right? It's like killing an embryo is killing unborn babies, right? Something like that. So it has a many ethical issue. And due to that, the adult stem cell will seize the what you call attention for the cell therapy, right? And then we also have herbal therapy. So I'm going to combine these two. Herbal therapy is a common one. I mean, for in India, we have in the north side, we have Ayurvedic, and in the southern side, we have Siddha medicines, okay? We have this. And the herbal therapy could use any part of the plant, from that root to the leaf, to the resins, to that bark, everything included. And not only that, like most of the time, how we consume the herbal therapy by extract. Most of the time, how we consume the herbal therapy. How do your mom cook palak in your house? Tell me, how? Huh? Boiling. What is a boiling? Aqueous extraction. You see, this all done by your parents and folks those days. So now we call them, we relabel them as aqueous extraction. Okay, that is how you cook, right? Using the water and the the heat. And we also can extract the herbal things from any specific extraction, ethanol extraction, methanol extraction, and sometimes we can isolate the phytochemicals. When you extract plant using ethanol, you may have tons of the phytochemicals. You have no idea which phytochemical actually working for. If you are going for drug discovery, the phytochemical is very important because none of the company will accept your idea if you're just giving them an abstract. They want a specific thing. This is where you can put yourself in the limelight. So phytochemical, sometimes polyphytochemicals. I think about 3 years back, I was in Gujarat. And the Ayush has mentioned about the polyphytochemical as the drug therapy for a patient. So this is all about the herbal therapy, right? Now, we get into a topic. Why we need this herbal therapy? Why we need the phytochemicals in terms of stem cell grow. You know, stem cell can be useful for many occasions. Those days, have you seen the dramas and movies, Bollywood movies? What happened if you want to kill a hero? The hero will have leukemia, right? So what does it mean? When somebody have leukemia, they will die. But that's all wrong with the stem cell. Now we can cure many of the terminal diseases with a stem cell, like a leukemia, right? And anything else? The bone disorder can be cured by the stem cell. Even some cases in the neurogenic disorders can be also leveraged by the stem cell. So most of the diseases once considered as a what you call end now can be treated with the stem cell. However, it is not easy to grow stem cell, right? How to grow stem cell? Any idea?
Conditioned media.
Yes? Yeah, is it easy? Okay. Here, who has an experience in culturing a stem cell? I produce stem cell every day in my lab. I have over 10 students, a PhD, hardcore research. We produce stem cell, multiple tissue. However, just remember that it is not easy to grow a cell, especially a stem cell in the lab. Because originally, these stem cells grow in your body, physiology, right? You have 3D compartment, you have extracellular matrix, you have an ideal niche for stem cell to grow. But can you reproduce this condition in the lab? It's difficult, right? So when you can grow up to a certain number, then they die or they become senescent, old, right? So how we can conquer or how do I say, how we can address this problem of growing a stem cell? By using phytochemicals, okay? The phytochemicals have become one of that critical point here to enhance the growth of the stem cell. When we grow more stem cell, it means you will have a more stem cell for research and also potentially for the application. That's why the herbal therapy and the stem cell mingle together, married together to form a new things here, right? And one of that, this is one of the, we can consume the stem cell and also the phytochemicals in a many manner. The first thing is the phytochemical enhance the viability and also reduce the cell death of the stem cell. As you know that growing stem cell is very important for the research and also for clinical trials. If you notice here, there are so many phytochemicals. These phytochemicals have an impact on many physiology of the stem cell and also normal cell in terms of proliferation, in terms of osteogenesis and pancreatic beta cell. Yesterday, your DY college has first pancreatic transplantation, which is a big achievement. However, you still can treat your pancreas with the phytochemicals with the help of the stem cell to regenerate them. I'm just giving you, see, if you want to be someone success in your field, you have to churn out very bright idea, new idea. So this idea all come from everywhere. So, and this is, here what I'm telling you is, besides know what's going to happen to the stem cell by using phytochemical, as a scientist, you should know what is a mechanism. There are tons of signaling pathways, right? Signaling pathways in the stem cell that enhance the proliferation and also reduce the apoptosis, okay? This one of the research as done in my lab. So we received a grant from the Ministry of Agriculture to test the potential of Moringa oleifera. Do you know what is a Moringa oleifera? It's a common food in Indians, right? Okay, I'm not very sure in North India, but South India is a very common food, and also in Nigeria. So what we have shown here is, by using Moringa oleifera, we have extracted Moringa oleifera leaf extract using ethanol extraction, and we also use the specific phytochemicals. The Moringa oleifera enhance that growth of the stem cell. You see this effective, concentration, okay? So when you increase that dosage of the Moringa oleifera, the growth of the stem cell getting more better and better. It also increases the cell cycle. What is a cell cycle? Any idea? Yeah, so you have the mitosis, you have a G0, G1, S phase and M phase, right? This is a cell cycle. Before one cell become a two cell, it has to enter a cell cycle, enhance the protein and duplicate the DNA to become two cell. So Moringa oleifera actually pushes the stem cell into a cell cycle. So like somebody pushing you to eat more. When you eat more, what happened to you? You become more round. That's the other thing. Okay, something like this. The Moringa oleifera pushes the stem cell into a cell cycle, so the proliferation of the stem cell become better. And the next data shows that Moringa oleifera also reduce the apoptosis of the stem cell. So I say this, I'm not very sure how many of you have an experience in cell culture. When you grow your cell in the vitro, they tend to experience apoptosis. It's a kind of programmed cell death, right? So with the Moringa oleifera, it reduced the apoptosis of the stem cell. So by using a Moringa oleifera, which you consume almost every day in Indians, what we call households, so you increase the number of the stem cell and also increase reduce the cell death of stem cell. So if you're consuming Moringa, why are you still getting old? That is where pharmacy comes in, bioavailability and absorption. You know ADME? Yeah, so you also have to relate that as well. Okay, and also I have here shown there are certain what we call phytochemicals from that Indian herbal. They can impact the other function of the stem cell, like a differentiation, okay? In the case of the hematopoietic stem cell differentiate into a red blood cell, white blood cell. And some of these, okay, phytochemical, they able to direct the stem cell. Let's say someone having anemia, right? Anemia is very common because one is a menstrual, other one is a lack of nutrition. So if you're able to find a phytochemical and able to find herbs or fruits that has the component that enhance the hematopoiesis and RBC differentiation, you can consume that. So actually you can address your physiological problem using a right phytochemicals and also the sources of the phytochemicals. That's what I'm going to tell here. And then, okay, so stem cell. Okay, what is all about stem cell? So you have a primary stem cell, you use them to what you call treat diseases. Is that the only capacity of stem cell? Can stem cell being consumed for the regenerating organs? What else you can do? Think about in terms of your pharmacy mind. What else you can do with the stem cell? If you manipulate stem cell, it can do a lot of things. This is where it comes drug delivery and the drug discovery. These two important things for you, how we can manipulate the stem cell to enhance the drug discovery and also drug delivery. And before that, I would like to say you something. Beside the normal stem cell, as you know that our body has stem cell, and stem cell become mature cell. Only one way, right? Can mature cell become a stem cell? Like a me, 46 years old, can I become 6 years old boy? Can I? Unless I'm a saint or siddha, right? But in term, actually you can. This is what's shown in the stem cell. Any mature cell can become stem cell. This is what won Nobel Prize in 2012. Where Shinya Yamanaka, a Japanese guy who has produced from fibroblast to a stem cell. It means although we're getting older, when we're getting older, we will have a lesser stem cell. That's the aging process. The person who aged die, why he died? Because he's lack of stem cell. Because when you age, the number of stem cell, the quality of stem cell as well reducing. And you die because one day, because there is no stem cell to produce your blood, there is no stem cell to produce your hair, there is no stem cell to produce your collagen, and you die because of old age. However, this can be, reversed with the iPSC. So the iPSC, inducible pluripotent stem cell, actually opened many doors in the pharmacology research. Okay, and one of them is, one of them is drug developments and cell therapy. So this is not so much of interest for pharmacology, but drug developments, right? So at the moment, if you want to develop a drug, what you'll do? Let's say you want to develop a drug for liver disease, fatty liver disease. What you'll do? Tell me, as a student, someone here is Pharm D, M Pharm, B Pharm, right? So as a student, you're given a task to develop a drug for liver diseases. What will you do? As a scientist, what will you do? Any volunteer? Anything, if any diseases, if you want to test on the liver disease,
We will see first pathology of that.
Yeah, that's a basic one. After that, how do you test? You have a formulation. You have come up with your own drug. How do you test the drug? Will you give it to human being first? No. What do you do? First of all, you will do a drug screening, in vitro drug screening. Then preclinical animal study. Then clinical trials. Okay. So the laboratory screening is very important, right? So how do you get liver cell? How do you get liver cell? The liver cell we have in our hand is mainly from cell line, a manipulated cell line, cell type. They are not behave physiology. Or we have animal. Does the mouse liver metabolism similar to human liver metabolism? No at all. So how do you test them out? One of the ways you test them out is to produce a disease-specific liver cell from disease-specific inducible pluripotent stem cell. Let's say I have some what you call, I wouldn't say any bad disease. Let's say I have some what you call liver disease, right? And it is genetically inherited. So I can take any cell of my body, right, make it as iPSC, a stem cell, and from that I can produce my liver cell. So the researcher do not require a human cell to do the pre-screening. They can do that with the iPSC. Do you see the potentials? Do you see the potential? I don't see here. Do you see the potential of iPSC to be used in testing drug? No, because, see, one thing is, most of you guys are so much focused on drug discoveries and formulation, but don't forget the biology. Why you need to produce drug? Why you need to produce a drug or medicines to treat a patient, right? To treat the patient, you should know the biology. So the biology actually comes from this sort of the works, right? Okay, so iPSC is very simple. I'm not going very detailed on iPSC. Anyone can produce iPSC by incorporating some genes into them, oncogene. Oncogene means a genes that change a normal cell into a stem cell. Okay, this has been an old story. I'm just telling you how you can produce an iPSC, right? And then this is one of the what you call an example. Let's say in the case of the thyroid disease, Hashimoto disease, right? So you have a hyper. You have a dysregulation of the hormone secretion. So what we can do is, I can take patient's skin, patient's what you call inner what you call squamous cell from that oral cavity. I can make them as iPSC, and I can produce the thyroid follicle. Here I can use, to test the drug, whether the drug which you have working fine or not, or I can study on disease modeling. What it means disease modeling? It means you study the pathology of the disease. Because without knowing the pathology, the biology of the disease, there's no point you produce a drug. Because although you're pharmacy students, the basic medical knowledge is so much paramount for everyone. And then it can be also produce for the cell therapy. That's the beauty about the iPSC. Now, In the drug discovery process, you have many elements, okay? One of them is drug modeling, target identifications, compound screening, which is more like a drug discovery, and also the pre-screening of the toxicity. The drug which you produce, it is what you call a safe for you, or it is not safe for you, something like that, right? Okay, so this is what you see. When someone, as a pharmacist, when you find a target identifications, so you have to test them, okay, from the primary screening up to clinical trial. So this is where the stem cell playing a major part. So in terms of primary screening, to have a better model, because most of the time in the biology, we use the animal model. Remember, animal model, although we are under one same mammalian family, mammalian group, but the physiology of human and the animal not 100% same. And the immune response in human and animal, it's not same. That's why you need a human-based cell. That cell can be harvested from the iPSC, right? You remember the validity of the data. So when you have a right system, right model that validate your drug or your data, you will be much wanted in terms of drug discovery, because you provide a valid data from someone who giving data from the mouse system, right? So your data much valid. Even the FDA, even the other authority, they will approve your approach much better as compared to the other person, right? The other one is disease modeling, okay? Disease modeling is important because the animal model, they don't have similar with the human being. And sometimes we use a human cell, but these are immortalized cell, a cell line. Cell line not necessarily have similar system with the primary cell. You know what is cell line? You know what is difference primary cell and cell line? If I take my cell from my body, it's a primary cell. If I take my cell from my body and I introduce certain genes, so I let them to grow non-stop, that is called cell line. So actually you are manipulating a cell. So manipulated cell not necessarily reflect the physiology. So either using an animal cell or even using a cell line, it doesn't give you a perfect or most wanted result. That's why I use the iPSC. Okay, so here there are some companies, okay, in the worldwide, they use iPSC to test their drug, okay, Encardia, Cellular Dynamics from Japan, Takara from Japan. Like Encardia, on the company, they produce a human iPSC, they produce cardiovascular neuronal cell, and to test the electrophysiology. If I have the cardio cell from the iPSC, human iPSC, okay, it will produce human cardiomyocyte. So I can test the cardiophysiology using the human cell rather comparing on the animal cell. You see how broad, how stem cell actually brought insight into a drug discovery and disease modeling. So you should appreciate that. These are new field. You want to grow to be someone very rich. You want to have rapid growth. In terms of that, have the knowledge on the new topics in the field. Then only you become someone who is visible, who is unique. Some people want to hire you. If you just follow the classical pathways, sorry, you just be in a big crowd, big population. The other one we have is drug delivery, okay? Now, drug delivery is one of the important. Okay, most of the time, let's talk about the chemotherapy. The chemotherapy is quite adverse to the human being. Besides, it kills the tumor cell, it also kills the other cell. Because the chemo drug are actually concentrated in your blood and your tissue fluids, right? However, if you use stem cell as a vehicle to carry the chemotherapy drug, what happens is, like a stem cell can migrate to the tumor very easily. Naturally, stem cell, especially a mesenchymal stem cell, they can migrate naturally towards the tumor cell. Okay, rather giving a drug to a person that goes to every part of the body, produce the adverse effect, you can incorporate the drug within the stem cell. So stem cell by naturally is go to tumor, When it goes to tumor, it can bring the concentrated drug to the tumor site to enhance the treatment value of the drug. Can you see that potential? And at the same time, it's also reduced the peripheral toxicity. That's why in the chemotherapy drug, people having a loss of that hair follicle, they have skin complications because of toxicity. So by using a stem cell as a mode, a vehicle to bring the drug, you reduce all those things, right? Not only that, it also is useful for those metastatic tumor. And one of that other what you call other example is mesenchymal stem cell. So you can genetically manipulate the mesenchymal stem cell to produce more cytokines, right? So since this stem cell naturally, okay, automatically goes to that tumor region, and it can overproduce the interleukin-2 and to treat or to kill the tumor cell. The case of glioma, interleukin-2 producing mesenchymal stem cells show great treatment potential. So we have many things like a PD-1. You know, recently a scientist got the Nobel Prize for PD-1, right? So immune checkpoint. So we can utilize many kind of manipulation in terms of the stem cells, so they can be used to deliver the drug at the part of the tumor, right? That's how it happens. No, because we see anti-cancer drugs are usually for proliferation, right? The proliferation is mainly for those highly proliferating stem cells, highly proliferating cell like a tumor. But stem cell is one of the dormant cell. It doesn't proliferate that much, so you don't see so much of impact. And plus, when you combine the drug to the stem cell, it doesn't impact the stem cell because the receptor ligations. It doesn't consume the stem cell to see the effect. It just attach with the drug, so you don't see the direct impact externally. That's what we do. And sometimes we also have something, we can manipulate the stem cells so they can produce pro-converting enzyme, okay? And that's also giving a better impact on the tumor management. And this is one of the examples here. See, in tumor, when you have anti-cancer agent, it is mainly in the periphery and blood. It only less goes to the tumor. But when you incorporate within the stem cell, it goes to the tumor, it releases the what you call drug and kill the tumor. Okay, that's how the drug delivery can be manipulated. Okay, why I'm keep on saying this? Because you wanted to be a unique person and someone who having a different niche in the pharmacology. These are the way to take home. And the other one is cancer stem cell. Okay, so we have a stem cell. We worked. And the tumor as well have a cancer stem cell. What is cancer stem cell? Cancer stem cell similar to the stem cell, but they also can self-renew. When I transplant one cancer stem cell into an animal, into an individual, the individual will produce a tumor. That's we call cancer stem cell. One of the biggest hurdle in the cancer therapy is you cannot fully treat the cancer. You always have a relapse. Why you have relapse? Because the cancer stem cell. All the therapy that meant for the cancer not necessarily work on the cancer stem cell. So there is also many other phytochemical has working as an impact on the cancer stem cell. As one of the example is curcumins. Curcumins. See how the curcumins here can work with the multiple type of the cancer cell through the mechanism, okay, to induce autophagy, to what you call reduce the signaling pathways, and and to increase the apoptosis within the cancer stem cell. So they utilize all these signaling pathways to reduce the number of cancer stem cells, right? So I'm almost done with my thing. So we have so much thing to be done on stem cell and herbal therapy in terms of the pharmacology. But remember, we have so much of what we call challenges as well. Okay, when it comes to using an extract, you have the pure compounds with the phytochemical versus the crude or enriched. Because when you want to do a drug discovery, you can't use crude extract. you have to find what is the key molecule, the key phytochemical that govern the impact of that herbs, right? The second one is bioavailability, right? So you may consume curcumins, tons and tons and tons, but does it all get into our system? No, there is also absorptions and bioavailability. So you have to tackle, okay? If anyone have a knowledge in Ayurvedics and Siddha, there we have also, whenever we treat a patient, we treat them with the adjuvant. We don't say adjuvant, we call as anupak. Anupak means a carrier that bring that what you call the potential phytochemicals to the body to be consumed. Okay, that's you have to also work out. And also then we have the stem cell versus cancer stem cell. Okay, so some what you call phytochemical like the curcumins, it helps the what you call stem cell reduce the number of the cancer stem cell. So how, you see, one single phytochemical work better on stem cell and it also reduce the viability and differentiation of the cancer stem cell. This is the beauty of the phytochemicals and the herbal therapy because it works based on what the body needed. Okay? So with that, I end my talk and I was much happy to answer any Q&A if you have.
Very good. We all have very lucid presentation by Dr. Rajesh, and it is so nice. Yes, friends, I am sure you all will agree. We had a very lucid explanation, kind of presentation with his own research that has delved into stem cell research and how it has implicated so many potential uses and what could be the do's and do nots when we are trying to do stem cell research. Before I open to the audience, I just need to clarify some of my questions and I'm sure this is a wonderful talk where you combined herbal, the potential of herbal extracts or isolated compounds, doesn't matter. As an Indian by roots, Dr. Rajesh, how would you select a herbal product to suit to the stem cell? Because you said in the beginning, there is a quality has to be improved and we need to select a proper herbal. How will you ensure this is the criteria before I choose an herbal?
It's very simple. So, Indian, remember, be proud to be Indian. You are inherited and humongous fortunates of the knowledge. Ayurveda and Siddha, nothing, you can find anything in this medicine. Like for me, I work on rejuvenation. Rejuvenation is a kaya kalp, right? So in the Siddha medicines, we also have listed what you call listed kaya kalp mulika, right? So I choose based on that. For example, I'm not very sure how that be transpired in Hindi or local language. In Siddha medicine, the herbs that what you call and name with a kanni. Kanni means ever youth. Karisalangani, Ponnangani. So the Siddhas, the Indian actually name that herbs based on their action on the body. So I took, because I have the basic knowledge on Siddha medicine, so I chose my medicines based on my research based on that manuscript in the Siddha and Ayurveda. And then, again, but what we are lacking is, we know this herb can cure this disease. This herb can be used for rejuvenation. However, what is lacking is how to combine this traditional knowledge with the modern medicine. So I brought the traditional herbs into modern medicines and by decoding the mechanism. So by using a Terminalia cebula is a katika. Is one of the components in Tripala. Not Tripala? Tripala is heaven in
Triphala, yeah.
Tripala. I'm telling you, all should consume that. I'm not promoting. Okay, so in Tripala, Terminalia cebula, okay, we know that it can be useful to treat the diabetes. But actually, what we have shown is we have extracted the Tripala's components, phytochemicals, and we tested them in the diabetic animal model and also human diabetic models. So we found that The terminal layer actually impact the insulin sensitization pathways and also intake of the glucose. So we decode. So we have the knowledge in the traditional Indian medicines. However, we don't know how to decipher. So my role is actually decipher the mechanism. The same thing. That's how I choose.
Very good, very good. And one more question, just a little. You nicely touch stem cell towards chemotherapy. And what are the other problems earlier when we encounter with the drug using chemical versus stem cell? There you are trying to project that by it can avoid number of side reactions to some extent. What are the major breakthroughs that has happened in these recent years when it comes to stem cell in cancer?
Okay. See, when I'm saying about stem cell can do this and do that, remember, not all of them actually translated into a practice. You see, like countries like Malaysia, US, UK, we do so much research in the stem cell, but not necessarily to be translated. Translating a research into a clinical trial, into a drug, is not a simple process, like a drug discovery as well, right? It involves billions of the money, right? So what we have done is, most of the research, what we have done are research on the laboratory research. Some of them are clinical trials. If you go to the National Health Institution in the US, you can find all the clinical trials that utilize the stem cell and also using chemotherapy. The beauty with the stem cell, especially mesenchymal stem cell, I work with the mesenchymal stem cell throughout my life. I start my research with the mesenchymal stem cell. Until now, I'm working on mesenchymal stem cell. So the beauty of this stem cell is, wherever you put in your body, if you have inflammation, this stem cell will go there. It's very simple. So tumor, what is a tumor? What is a cancer? Cancer is a chronic inflammations, right? So you have a tumor in your liver. You just inject the MSC in your vein. It will go everywhere, but then it will accumulate in the site of the tumor. So as compared to the other chemical entities in vehicles, stem cells serve as a specific accumulation points toward the tumor and inflammation. This works well with the mesenchymal stem cell and some extent to the neural stem cell. That's why we choose the stem cell, because the biology, it is not in a chemical entity.
Sir, session is open for the question.
Yes, please. Yeah, so thank you so much. So like in my lab, we produce the stem cell from umbilical cord, adipose tissue, almost every day, okay? However, you see, one of the most controversial stem cell is the mesenchymal stem cell. Why? Because until now, there is no unique characterization of the mesenchymal stem cell. We use a very vaguely defined markers of the stem cell to define MSC. Okay, the MSC I have in my lab and in your lab not necessarily same, right? So that's why you have to determine the potential of the stem cell. Like in the case of the immunomodulation, right? If you want to use the mesenchymal stem cell for immunosuppression, the best stem cell is bone marrow MSC, because in the bone marrow, it grows with the hematopoietic stem cell and T cell and B cell. It has got connection. If you want to use the stem cell for the tropic effect, for aesthetic, adipose-derived stem cell will much preferred. Like we also can produce a stem cell from the chondrocyte, right? If you want to use the stem cell for bone regeneration, the chondrocyte-derived stem cell is important, is preferable. So if the stem cell come from the close source vicinity, it will be much easy. However, this is not something written on the stone. It can be changed based on the culture media you use. Nowadays, I'm telling you, people no more using cell. People using acellular therapy, exosome. See, you want to excel in your field, right? This all, you know what is exosome? What is exosome? Tell me, lady. Ah? It's okay, it's okay. You see, That's why our veterans, our legends here just now, they say knowledge is important. You can be whoever you want to be a vertical millionaire overnight. But if you don't have a knowledge, how to be? See, knowledge is a paramount. Exosome is a molecule produced by any cell, especially stem cell. Nowadays, we don't treat the patient with the stem cell. We use a secretum from the stem cell to treat them. If you wanted to be millionaire, use this kind of a technology, right? So we use plenty kind of, we use a secretum, we use the exosome, we use the other part of the stem cell to treat the patient. So it's become acellular therapy. From cell therapy, it become acellular therapy. So in my lab, we also working on exosome for the diabetic wound repair. Like we can harvest the exosome from that from the MSC. Remember, if a normal stem cell produce normal exosome, let's say I want to culture my stem cell with the herbs. What herbs you use for wound healing? I have no idea name in that in Hindi. We have Kuppameni. I have no idea how to say it in Hindi or in Latin. These herbs are known for skin ulcer, or recall healing, this and that. So what we do is, we take extract from this herbal, culture our stem cell, we harvest the exosome, we profile the exosome, we treat them. These are the things to be think by you guys. Your young scientists, young mind, use your knowledge, the knowledge you have from your forefathers, use your knowledge in your modern medicine to develop some kind of the treatments. So that's what we do. Like a Moringa oleifera. I'm giving you one example. So what we have Moringa oleifera, okay? What we have done is, we done this work on animal. We make a mice immunosuppressant. These mice don't have any immune cell because we kill the bone marrow. And then we treat the mice with the Moringa oleifera for 30 days. We found, we have also control, and we also have positive control, immunostimulants. Those mice that receive Moringa oleifera, the number, the quantity, the quality of the stem cell and immune cell we receive are much better as compared to the standard gold standard treatment. You see, so this is how you have to combine the stem cell and your phytochemical. This is what we call Kaya Kalp. Use what you call the knowledge you have in your genes, because you all come from all these forefathers, right? For the modern medicine, for modern research.
That's well said. I'm sure because of the lack of time and of course interesting topic, whosoever is interested, you can have some discussion with Dr. Rajesh during the session or afterwards. Maybe we should move on to one. Sir, we thank you very much and being involved. Just to sum up the potential use of stem cell towards this, how do you see in the coming years that we can still have the full confidence in treating the disorder using stem cell?
Again, I'm coming from pure...
There is direct answer I want.
It will take a few years, because all research, the things which I'm presented are from research from a lab, preclinical work and clinical trial. Only stem cell that been in Malaysia, in a government vicinity, the only stem cell used is hematopoietic stem cell to treat the leukemia. All others are still clinical trials and the research. Don't be fooled with the pseudoscience. No, don't be fooled with the pseudoscience. If you want to do something, do with the proper scientific interventions. Thank you.
Thank you, sir. I request Dr. S.S. Bhujbal and Dr. V. Adipalli to please felicitate Dr. Rajesh Ramasamy with memento as a token of gratitude. I also thank chairperson and co-chairperson for conducting the session. I request Dr. Vikram Chaudhary to felicitate chairperson and co-chairperson, Dr. S.S. Bhujbal, Vice Principal, GPU Pharmacy. Dr. V. Adipalli, Research Director, DPU Pharmacy. Thank you all. For the next session, we have Dr. Sneha Ambani, Professor and Head, Department of Pharmacology, All India Institute of Medical Sciences, Jodhpur, Rajasthan. For this, we have Chairperson, Dr. V. Adipalli, Research Director, DPU Pharmacy, and Co-Chairperson, Dr. S.V. Dange, Professor, Department of Pharmacology, DY Patil Medical College Hospital and Research Center, Pimpri, Pune. Instruction for the student. With respect to poster presentation, we are going to start with poster presentation for the groups 2 to 4. I request only 7 students from the group to proceed for the presentations. Only 7 students, other be seated in the room.
The biodata or CV which has been given to me is quite exhaustive, and some salient features are there on the screen. But again, I would like to emphasize some important points, that she was awarded Spotlight as a renowned life member with significant contribution in pharmacology and clinical pharmacology and therapeutics by National Association of Pharmacology and Therapeutics in last year. She also got the Best Paper Award by Indian Pharmacology Society at IPS conference held in Ahmedabad in year 2000. So this is quite remarkable. At her age, she is getting Best Paper Award, whereas I have stopped reading papers in conferences. That is something to be learned from her. Then she was awarded International Certificate of Principles of Bioethics and Human Rights under UNESCO Chair Bioethics in October 2018. And the other things are also there. It will take a long time to read if I want to do that. So I will stop here. I request Madam to talk on her topic, that is good clinical practices and guidelines for biomedical research in human beings.
Thank you very much, sir, for nice introduction. At the outset, I will thank you all the organizers, Mr. Vikram and this DY Patil administration, to invite me here to present something related with clinical trial. Again, it's a very big topic. It took almost a day workshop when we discuss clinical trial as such. I'm going to stress only on the ethical issues. As Dr. Rajesh said, transmission of the knowledge is very important. Once you identify the stem cells, as he said, transmission or application is very difficult. It have lots and lots of ethical issue when you talk about the use of anything, whether it's a stem cell or drug. There are lots and lots of ethical issues when it comes to the use in human beings. And my basic topic is how to learn or how to do these or over these ethical issues while doing any clinical research, right? You identify the molecule, you find out the molecule, but how to transmit in the human beings, that's again a big issue, right? So we will discuss, as topic says, good clinical practice, and their government has laid down so many guidelines. Initially, we were following or obeying international guidelines, but recently in 2017, ICMR, if you know, Indian Council of Medical Research, Indian body, they lay down certain principles, guidelines for research in human beings. That is known as Good Clinical Practice Guideline. That is laid down in 2017. Clinical drug trial rules, they were also there, and recently they make an amendment in 2019. So now we are following clinical guidelines laid down by ICMR as well as by the CDSCO in 2019. So I will discuss only salient features of all these and how to do any research. That's biomedical research on humans, right? So this is the disclaimer. All these views are mine, not related to my institute. So at the end of the session, we'll be able to know introduction or definitions, various principles, and various principles which are laid down by ICMR. We'll discuss these one by one. So can you define by now what is good clinical practice? Or will you define good clinical practice? Name itself suggests. And why it comes in the action, or why it is required. No? So it is, when we say good clinical practice, it is starts from conceptualize. When you conceptualize any subject, right, any project or any research, it starts from there. So by definition, if we'll say, it is an international ethical and scientific standard for conducting any research, biomedical and behavioral research involving human participants. And that starts from designing to actual implementation, right? When you design a clinical trial protocol, that starts from there. Why it comes, why we think about this, this good clinical practice in human research? Is there any incidents you remember which make us to follow these guidelines? So history actually.
To protect the human rights.
Right, because in past, various studies was conducted by using or abusing, I must say, human beings, right? So in the past, that was the history. So what makes us, why it is required? Because in past, various or humans were misused, so that, misused to nahi kahungi, abused, right? In what concern we say they were abused or misused? Kaise kahenge? What is the? So we'll learn to in due course of time. So whenever they were used, any drug was tried without concerning the safety as well as right of the human beings, right? That is nowadays important. So when it was happened in the past, and two important incidences are there if you go through the history of clinical trial. One is Nuremberg's trial that was happened in from early 1942 to 46 for 4 years by using Nazi prisoners, right? And another important one, which was almost conducted for 40 years, 40, from 32 to 72. And that was on patients with syphilis. In that trial, these black Negroes of the UK, they were given, those who are having syphilis, they were not given this penicillin. They were entered in the clinical trial without their knowledge. And at that time, just to know the normal course of the syphilis. Syphilis was a new entity at that time. So just to know what is the actual course of the syphilis so that Britishers can be protected themselves, right? Meanwhile, penicillin was invented and that was found effective in syphilis. But those Negroes who were in the clinical trial, they were deprived of that penicillin. They were not given the penicillin. So that was break in the, or unethical. So it was unethical. When you have any treatment for any disease and if you deprive your patient, that is unethical. So it took almost 40 years to conduct that clinical trial. Because of that, almost 128 patients were died because of syphilis. So many children were born with congenital syphilis, right? And so many wives of those husbands, they were also have the same disease. right? So that was found unethical. And if you are interested, this Obama also apologized for that clinical trial in recent past years. And there is one famous movie on that, that is Miss Avers Boys, which was depending on this clinical trial. If you are interested, you can go through that movie. So just to protect the humans from all these unethical exercise or unethical outcome, this good clinical practice comes into action. So it's a protection of rights, safety, well-being, and confidentiality of the participant, accuracy in collecting the data, that is also again an important. So when we say good clinical practice, there are 4 principles. That is, one is to protect the right, to assure the quality, reliability, and integrity of data, and to provide the standard guidelines, right? So whenever you're collecting any data, it should be ethical and good quality data. Whatever we are getting, novel molecules se leke stem cells, I must say, we should be honest enough while collecting the data, right? So that is good clinical practice means. Now we'll discuss, this is the history. I already mentioned this. Nuremberg's code was there in 1947 after that Nuremberg study. And after that, earlier, all these drug development comes under Food, Drug and Cosmetic Act was implemented in 1930s. If you remember, in old days, opium was given to the children, sula do fatafat, so jayega, de do usko. That was again unethical. And all these drugs, all these remedies comes into a Food and Drug Act after 1930. So that is there. Then Declaration of Helsinki, that is related with the safety and efficacy of the various participants who participate in any study. Then in 1979, it is related with, it's for the safety, its report has come that is related with the benefits, justice, and respect to your participants. They don't say they are patients, they say participants, those who are entered in your clinical trial, that is there. And that is in 1997, this International Council of Harmony or GCP guidelines, that was international guidelines, they were implemented. But after that, ICMR laid down their own guideline in 2017. Now we are following that. So this is the history of this good clinical practice. So this is a booklet which is available online if you are interested. There is a big booklet which is developed by ICMR. So I'll just discuss in short principles of good clinical practice or guidelines. We are a pharmacy people, but you should know that what is basic difference between clinical practice and clinical trial. Medicine तो आप ऐसे भी patients को देते हैं. Being a doctor, we also treat the patient by drugs. So what is basic difference when we say it is clinical trial or clinical science or treatment when you give to the patient? So in routine medical care, we also treat the patient by medicine, but there is certain difference between clinical trial and medical practice. One important thing which I highlight is there are strict inclusion-exclusion criteria are there in any study. To whom to include, to whom to exclude. That should be there in clinical trials, but that is not in clinical practice or medical care. Time bound is there. Complete follow-up, that is, we will do the study for a limited period. Patient care to throughout the life rahega, jab tak patient hai, tab tak we have to give the care. And then you have to notify the adverse effects. There are principles how to notify the adverse effects when we are doing any clinical trial. So there are 13 principles laid down by ICMR. First is principles of essentiality. That is, you should know whatever you are doing, is it essential? Because right now we have discussed that from development to translation, it took time as well as money. So lots and lots of money is involved when we develop a molecule to a drug, right? So whenever we are doing any research, whether it is a preclinical or clinical, we should know, is it essential? If it is essential, you have a new concept, then start the clinical trial. Second is principle of voluntariness. We see, as I discussed in that Tusky trial that I have explained in which was conducted in patients with syphilis, that is known as Tusky trial. So in that trial, no consent was taken from patients. They were included in the study. So second principle is voluntariness. Patient or participant should voluntarily participate in the study. They should not be forced to participate. Participate in the study, as well as they have right to withdraw from the study at any point of time. Aaj hai, kal na rahe, nahi. That is their choice. So that is principles of essential voluntariness. Principle of non-exploitation. That is again the same thing. You should not exploit your participant. Agar aisa nahi karoge, to aisa ho jayega. Not like that. Next is privacy and confidentiality should be maintained. If in any case, if you are enrolled a patient in your study and you found he or she is having some disease, which should not be disclosed. You should make or keep the confidentiality of his or her whereabouts. You should not disclose to anyone. Then principles of risk minimization. Whenever we are using drug, pharmacology padha hai aapne, no drug is devoid of any side effect, right? So whenever we are using any drug to a patient during clinical trial, try to make it the risk to the patient is less, minimum. Benefit ज़्यादा हो, risk कम हो, right? Then comes principles of professional competency. काम वही करो जो आपको आता है, right? मैं pharmacologist हूँ, physician हूँ और मैं radiology का काम करूँ, that is not my competency, right? So whosoever is doing the research should be competent enough to do that research, right? Which is your field. हर दूसरे के field में नहीं घुसने का. दूसरे के लिए दूसरे को छोड़ दो. You do whatever you are efficient to do it, competent to do it, right? So principle of competency, professional competency is the another principle. Accountability and transparency. So very important. आप जो कर रहे हो, you are responsible for that. Take the accountability of that. इसने नहीं, उसने कर दिया, उसने कर दिया, इसने कर दिया, no. When we do clinical trial, there is a one term, principal investigator, right? So it's a duty of the principal investigator to take the accountability of all the done do's and don'ts for any clinical research, and transparency. Transparency in doing work, enrollment, as well as for data collection. That should be there. Principles of institutional, that is related with your working complex where we are working. If you have all the facility to do that particular research, then and then you only start that research. Principles of social responsibility and principle of compliance are the another important. Do the research which is common at your area. है ना, यहाँ पे की बीमारी की साउथ अफ्रीका में जो बीमारी हो रही है हम यहाँ रिसर्च करेंगे, that will not helpful to our society, right? So that is there. So these are the various principles. Now, as I mentioned, in 2019, this ICMR has laid down the new clinical drug trial, and these are the two changes in the recent one: the precaution and risk minimization and totality of responsibility of a principal investigator is included. So these are the common principles. We'll just discuss how you can do it. कैसे करना है, पता तो है, but how to do it, right? So all these principles we can divide into 4 major principles, ethical principle. One is beneficence. That means benefit and harm or risk ratio. Whenever you do any research, you should weigh down the what are the benefits and what are the risks. That is principle of beneficence, non-maleficence, justice, respect, and integrity. These are the 5 major principles of any clinical research, right? So when we say respect, we'll discuss in detail one by one, right? So when we say beneficence, that is, we should do benefit to the patient, not the harm. You should weigh what are the benefits when we are doing any research to the patient or society, and what will be the harm. If it benefits are more, then and then your research will be fruitful. Harms ज़्यादा होंगे तो there is no point doing that, right? So आपके यहाँ है ethical committee है? Do you have an ethical committee in your institute? Right? So there is an ethical committee both for animals as well as for humans, institutional ethical committee, right? So whenever you do any research, you have to submit your protocol to the research committee, and they have to weigh all these things, right? So we can categorize the risk, types of risk: physical risk, psychological, social, economical, or legal risk. So these are the type of risk. Benefits की बात करें, direct benefit, indirect benefit to the society or local community benefit, that should be done. Then comes non-maleficence. नुकसान नहीं होना चाहिए, फायदा हो ना हो but नुकसान ना हो. Risk is different, beneficence is different, right? So that should be there. So it's a duty of IC, Institutional Ethical Committee, to check whether it is beneficial or harmful, right? So when we say harmful or non-maleficence, that is, we have to classify our project or our research into 4 categories, right? When we say no risk, कौन सी होती है research जिसमें कोई risk ही नहीं है? There is no risk. जिसमें IC की भी जरूरत नहीं है कोई ऐसा research? कोई डाटा पड़ा है डोमेन में, वहाँ से उठाया, कलेक्ट करा, and then will submit the project. That is no risk, right? Questionnaire based study है, there is no risk, right? So that is a minimal risk. That is the decision of IC. Then comes more than a minimal risk. That means routine practice में आप ले रहे हो, sputum, non-invasive जिसे कहते हैं, sputum ले लिया, right? यूरिन ले लिया, टेस्ट करा जिसमें, क्वेश्चनर बेस्ड कुछ करा, राइट? सो दैट इज जस्ट मोर देन मिनिमल. देन कम्स, सॉरी, देन कम्स हाई रिस्क. हाई रिस्क में इन्वेजिव और नॉन इन्वेजिव प्रोसीजर जो भी होता है, एंड देन इट कम्स टू द हाई रिस्क. So depending on the type of risk, where IC will come into action. And that says 3 types of review: exempted review, expedited review, and full board review. When it is a invasive, high risk research, full board review should be there. I don't know how many students or persons sitting here know about the IC. सुना है कभी IC के बारे में पता है? चलिए, कितने मेंबर्स होते हैं आईसी में? How many members, or who is the chairperson of IC? Animals also. Animals का different है, humans. Ethics committee is there. So this is the duty of IEC to analyze the risk to the participant. Selection of participant is equitable. Informed consent, that is more important. Informed consent is the integral or important part when you are doing any research. कभी is anyone is involved in any research? कराया किसी ने research? है कोई project submit कराया किसी ने? M-Pharm में तो करते हैं शायद. ओके, आप फार्मेसी वाले कोई नहीं करते? Pre-clinical only. Okay. So usme bhi to we have to submit the project. So what is informed consent? So whenever we are enrolling your patient for any clinical study, we have to take the consent, right, in writing. That is known as informed consent. And before that, you have to explain each and everything regarding your research project. That is CRF dete, patient API, patient information sheet, PIS, right? What to do, how to do, when to do, right? So that is there. So it is the duty of the IEC to see that informed consent is properly obtained and documented. Adequate provision is meant for monitoring, right? So that is there. Protection of the participant and safeguard to the vulnerable population. कौन सी रहेगी vulnerable population? Poor to labor. One is, another is children, or you are also a vulnerable population. You yourself are vulnerable. नहीं? सर ने कह दिया participate करना है तो करना है. Vulnerable. We are also, students are vulnerable population, employees are vulnerable population, right? So, children, employees, military person, mentally retarded person, right? They all are vulnerable population. Prisoners. So type of review, I already discussed. It's depend on the type of risk involved. When we say less than minimal risk, low risk and high risk, these are the type of reviews. Exempted review, no need of required IEC permission. Low risk में expedite. अभी COVID में हुआ था, उसमें क्या हुआ था? What happens in COVID? There were so many clinical trials were going on during COVID. So, वो कैसे हुए? उनको कैसे मिला? They were exempted. No? Or expedited. They were expedited clinical trials without review board. Otherwise, because we don't know what will be the risk of all these vaccination के trial हुए थे ना, पढ़ते हो, पढ़ा होगा आपने. So they were, few were exempted and few were expedited. That means they were given temporarily permission to conduct clinical trial, but in due course of time, they have to submit the related documentation regarding the safety and efficacy of that vaccine, right? So that is there. So full review is required whenever there is high risk in your clinical trial. So this is again the role of ethical committee to see the, or to calculate the risk. So these are the some measures you can take while doing any research to minimize the risk involved in the clinical research. Documentation, ये वैसे तो आपके है नहीं. Whenever you are submitting any project, this is what is required to submit to the ethical committee. It's related with both animal as well as human committee. What we will do, where we will do, when we will do, why will do, and who will do it. Or who से भी start करें, who will do it, what we will do it, where, when, and why. Right? So that is the SOP related with any clinical trial or any research, we must say. When we talk about the clinical trial, when it is a new drug, DCGI approval is mandatory and CTI registration is mandatory whenever do any clinical trial. It's again a big process to discuss all these things. I will not go in detail, right? COVID has changed a lot while doing or assessing all these clinical trial. Before COVID, physical meetings were mandatory, but after that, hybrid mode is accepted. Even during COVID, online or virtual meetings were accepted to review the all clinical trials. That's why I told you this is expedited and exempted trials, right? So that is hybrid mode is allowed, documentary evidence is preserved, and this is all Sugam portal that is for the clinical trial. Changes again, that is related with IEC. I don't think it is required for you people. So that was the non-maleficence, that is, you have to assess the risk, and depending on the risk, review committee will decide how to do it, whether it is expedited review or full board review. Then comes respect your patient, right? उसमें क्या आता है? Informed consent, care of vulnerable, and privacy and confidentiality. When we talk about informed consent, whenever we are participate in any study, have you filled any informed consent? भरा है कभी? क्या क्या होता है? What are the different parts of informed consent? क्या होते हैं? First is title of your study, what you'll do. Then, who will do it? Name of the principal investigator is contact number or details of the principal investigator. And then, name of the participant. Then he will give the consent. He is or she is participating voluntarily without any pressure, right? चलो नहीं पूछते कुछ डिफरेंस है व्हेन यू आर एनरोलिंग योर पेशेंट इफ ही इज एन एडल्ट और माइनर कुछ डिफरेंस है बच्चों में रिसर्च करते हैं तो व्हाट इज द डिफरेंस लीगल ऑथराइज पर्सन का लेते राइट कब तक एज है डिफरेंस अप टू 6 years और 6 to 12 years एंड देन एडल्ट कुछ डिफरेंस है 6 years तक पेरेंट्स का अलाउड है 6 to 12 years वर्बल कंसेंट फ्रॉम द चाइल्ड प्लस रिटर्न कंसेंट फ्रॉम द पेरेंट्स और लीगल गार्जियन एंड एडल्ट में patient himself or participant himself, right? So that is the regarding informed consent. ये parts है study purpose, randomization, how will you do it, what is your duration, benefit, cost. ये आप patient information sheet बनाते हैं while doing any research, and these all are the parts of that. You should give it to the patient, right? कि हम क्या करेंगे, कैसे करेंगे, blood लेंगे, urine लेंगे, X-ray कराएंगे, sonography करेंगे, whatever. You have to explain to the patient. So that is the part of your patient information sheet. And once he will read out and accept to participate in your study, then he will give or she will give the consent, right? So these are the different paths. So that is their nature, alternative. Another important thing, if your patient is having some disease, you should give assurance to give the ancillary care to the patient. That means, जो ले रहा है उसको बंद नहीं करना है आपकी ट्रायल के पीछे. And whatever happens, if something happens to the patient, you will provide the care to the patient. That is ancillary care, right? During the period of your clinical trial. Confidentiality of personal information, I already discussed. You should not disclose to anyone. Then new information that comes to study contact and number of people, that should be in your all research projects. So that is your informed consent. Now comes to the confidentiality of clinical trial. Already mentioned, you should maintain the confidentiality of your details or whereabouts of your participant. And if during your study period, if something's come out, that should not be disclosed to, right? Whatever data we are generating during your research, that also to be kept confidential until unless publicized, right? But उसमें भी anonymous data जाता है, patient का detail नहीं जाता है. All these should be kept in a lock and key, should be accessible to the principal investigator or related or the person who is authorized by principal investigator. ऐसा नहीं किसी ने भी खोला चाबी खोल कर निकाल लिया. So that should be there. That should be kept in lock and key. Confidentiality is maintained. But there are certain incidences where we have to disclose the details of your patient, right, or participant. If you find that he or she is involved in any criminal activity, right, and if you found that his behavior is changed, any behavioral study, if it is changed, then you have to disclose it. If patient is having some communicable diseases, then you have to disclose it. Otherwise, transmission of disease will be there if you will not disclose. और क्या क्या हो सकते हैं? और कब disclose कर सकते हो? कुछ idea? Legal orders होते हैं, that's suspected child abuse, armed forces, medical emergency, research activities में कुछ है, danger. अगर patient अपने आप को ही danger में कर रहा है, and if you are doing some research on any psychological drug, then we have to disclose it, right? कि he is or she is on the treatment. और सबसे मुश्किल court order. Patient is involved in somewhere else, and if court order you कि please disclose the details of your participant, then you have to disclose the confidentiality. एक exercise है आप लोगों के लिए, पढ़िए इसको. An investigator completed a clinical trial and published on the result of the study. Researcher for another study read the publication and contact the study investigator to request the sharing the data with de-identified participant data. The study investigator shared the de-identified data, says the researcher. Right? So is it a breach in confidentiality or not? Yes or no? How many says yes? And how many says no? Or how many are neutral? So, who says yes, breaching confidentiality? No one? Or is it, or yes or no? How many for no? Only one? Baki yes? Confusion. There is a word, de-identified. That means we are not disclosing the details of your patient. Right? So de-identified data, and they are sharing just data, not the details of the patient. So there is no breach in confidentiality, right? So that is the answer. Study data be disclosed for data shared is de-identified, right? एक और exercise है, इसको भी पढ़िए. After confirming Mary's date of birth, and he shares that he says that Mary is enrolled for HIV clinic and she cannot go into the details of Mary's treatment. So is it a breach or no? Again, no. There is a breach. We should not disclose to even to the closer one. Even mother से ज़्यादा कोई close नहीं, to anyone. Until unless patient or participant give consent, कि हाँ, you can disclose it. Otherwise, we should not disclose it to anyone. So that confidentiality, आप समझ सकते हैं, to maintain during your clinical research. That is the importance of confidentiality, right? Then comes justice, right? When we say justice, there should be no discrimination. मतलब no discrimination at what level? Every level. To enroll, to give the facility, to give the monetary, financial support भी देते हो, incentives भी देते हो, in that way. No discrimination, right? Caste की वजह से, right? जो भी है, you should not discriminate gender, caste, state, border, right? ये है आपका, कोई डिस्क्रिमिनेशन नहीं होना चाहिए. एक को बहुत ज़्यादा मिल रहा है और एक को कम मिल रहा है. एक और वर्ड आता है benefit or burden should be shared equally. When we say equally, there are two terms, equality and equity. दो terms हैं, ये दो diagram हैं. ये क्या है? What does it shows? थोड़ा आंखें खुले, नींद आ रही है. चलिए. Can see? In first picture, what is there? Equality. What does it mean? देते जाओ, जरूरत है ना है देते जाओ. Right? So that is, and what is? Equity. क्या है देखिए आप उसमें? You can see? इसको दिख ही नहीं रहा, इसको जरूरत नहीं है एक और दे दिया. Right? जिसको जरूरत है उसको दिया नहीं. So this is the justice. जिसको जितना ज़रूरत है उतना ही, नहीं ज़रूरत है तो देने की ज़रूरत नहीं है. So that should be there in your clinical research. We should follow the rule justice of equality as well equity. Equity होने चाहिए. ज़्यादा को ज़्यादा मिल रहा है, कम को कुछ भी नहीं मिल रहा है. That is not followed in our country. So very sad about us. Right? So that is there. Justice to the participant should be there. उसके बाद आता है यही, when we say, I already mentioned, there should be no discrimination regarding gender, caste, state, right? So fair distribution to the right, ethics, balance and justice. पांच चीजें थी, rights, ethics, balance and justice. That makes the equality, and there should be equal distribution. So whenever we say justice, there are three types of justice. Distributive justice, जैसे पढ़ा देखा अपन ने, procedural justice. जो भी procedural करो, whatever you are doing, it should be the same. ऐसा नहीं एक patient आया उसको तो अच्छे से इसी में बिठाया और एक को बाहर रोड पे खड़ा कर दिया. Not like that. Procedural भी justice होना चाहिए. Same procedure, same instructions should be followed to all the participants. That is procedural. That is ensure that process is justice is fair and impartial. Compensatory justice, इसमें ये है कि whenever you do any research, there is a provision to provide some compensation if adverse effects or side effects occur. That we'll discuss in one slide next. So that should be again shared equally, right? ऐसा नहीं है कि हमारा जानकार है तो उसको ज़्यादा दे दिया, and if no one is there, no big shot is there, we will give to him or nothing, right? So distributive justice, procedural justice and compensatory justice, that should be equal to all the participants, right? That is again a principle. Last, conflict of interest and misconduct, that is suggestive of integrity. अगर आपको याद होगा, हमने एक हिस्ट्री पढ़ी थी, बेलमोट रिपोर्ट, राइट? बेलमोट रिपोर्ट says all these five: justice to the patient, no harm to the patient, respect your patient, right? That is the Belmont report says, right? उसके बाद ही essentials of ethical principles आए. So now you can say what are these principles are, right? So when we say integrity, then comes conflict of interest. क्या होता है conflict of interest? कुछ फायदा हो तभी कुछ काम करें, नहीं तो क्यों करें, right? So whenever you are doing research, is there any conflict of interest? I say yes. क्या है conflict of interest? प्रमोशन मिलेगा रिसर्च करोगे तो, किसी इंडस्ट्रीज के थ्रू करोगे तो फाइनेंशियल बेनिफिट मिलेगा. यस, सो दैट्स योर conflict. So when we say conflict of interest, it's a set of conditions where professional concern in primary interest such as participant welfare, validity of research be unduly influenced by a secondary interest. Primary interest अपना क्या था? Research, but it is secondary research that may be financial or non-financial. Non-financial में वही promotion है, accreditation है, appreciation है, that is all non-financial. Right? It can be at level of researcher himself, EC board and sponsors. हम लोग sponsor और IC की बात नहीं कर रहे, हम researcher की बात कर रहे, right? Principal investigator की बात कर रहे. So is it a bad thing to have a conflict of interest? होना चाहिए, होना चाहिए मैं कहती हूँ. क्यों नहीं होना चाहिए? भी काम कर रहे हो, आपको appreciation मिलना चाहिए, financial support भी मिलना चाहिए, क्यों नहीं मिले? The only thing is, there is no harm to have conflict of interest. Have to disclose it. That's it. By doing this research, I will get this. That's fine. नहीं, आप sponsor मिला है आपको, आप research कर रहे हो, disclose it. The funding for this particular research is from so and so company. That's it. Right? So there is no harm in conflict of interest, having conflict of interest, but you have to disclose it fully. Right? So, whenever you have any conflict exists, आजकल तो examiners में भी सर आता है, conflict of interest का form भर के भेजना होता है, कि do you have no relatives, nothing. So many clauses are there when you go for examinations, right? So you just write down, no, I have no conflict of interest, that's it. Right? If you have, then say it. There is no harm in it. So disclose it, talk about it, कि है नहीं है, and mitigate it. You have, then do it. No harm in it that. Then comes research misconduct. Integrity की बात कर रहे थे, एक conflict of interest था और एक research misconduct था. क्या क्या होता है research misconduct? सबसे इम्पोर्टेंट बहुत होता है, आप तो बंद हो गया. सलामी पब्लिकेशन सुना है कभी? What are सलामी पब्लिकेशंस? नहीं, पब्लिश करते हैं, पेपर वगैरह पब्लिश करते हैं फैकल्टी. क्या हो रहा है? There are three major misconduct when we talk about the research. One is fabrication, that is making up data or result and recording or reporting them. इधर से लिया और publish कर दिया, that is fabrication. Falsification, name itself suggests, आधा जो आया उसका उल्टा सीधा करा के अपने जो काम का था, whatever is of your interest, you show those data or those results only, right? एक third important है plagiarism. That is, आजकल तो authenticate आ गया है. We have to check it. How much plagiarism is there? कितना है acceptable आपके thesis के लिए? 10%. 16 to 20% is acceptable, right? So that is there. Salami publication is when you do one research and get 4, 5, 6 publication from that one research. Data तो एक ही है, but if you publish it in a different way, that is known as salami publication. एक ही research है उसको multiple times with different mode कह लीजिए या addition, alteration करके you publish it, right? So that is salami publication.
Madam, can we have in another 1 or 2 minutes? You can close down, if it is possible. Yeah, that's good.
So whenever you find any conflict of this misconduct, you should punish it, right? That should not be taken is simple. Quality assurance, आपका whatever data we are generating should be having good quality data, right? Documented, reported. Documentation, again, as I mentioned, it should be properly documented in lock and key. Safety and adverse event, that is very important. So that is, again, whenever there is any adverse effects occur to the patient, we should inform, right? There is a channel to informing all these. These are the 6 types of serious adverse events whenever you are enrolling any patients. If death occur, that is considered as severe. Adverse effect, hospitalization, prolongation of hospitalization, significant disability, congenital birth defect to the child, and life-threatening condition. These are considered as severe adverse effects. Then comes, these are the channels, मैं जो बता रही थी आपको, कैसे कैसे inform करना है, right? Yellow में है first, आपको ethical committee को inform करना है, and if it is an inform sponsored trial, तो आपको उनको भी inform करना है, right? उसके बाद आपको head of the institute, that is the second channel. Ethical committee will review all these adverse effects by a special committee within 30 days, give report to the DCGI, and then DCGI will again revert back within 105 days and then give compensation to the participants. So that is the channel how to report ADR and how we will get compensation. When we talk about the compensation, it is a formula by which we will calculate. It's the standard formula है BFR multiplied by 99.37. Base amount तो 8 लाख तो minimum देना ही है patient को, right? For as a compensation, F is factor depending on the age, R is for risk factor. So each and every individual, each and every research have different figure, right? ये सिर्फ death का बताया मैंने. This is the formula how to calculate the compensation if death occurred during any clinical trial. अगर range की बात करें, it ranges from 8 to 78 lakhs, depending on the age and risk factor. So, इसको भी जाने देते हैं. So take away messages. Whenever we do any research, think about ethics, integrity, and values. When we talk about ethics, it is do my actions are right. अपने आप से बात करिए कि मैं जो कर रहा हूँ सही कर रहा हूँ, नहीं कर रहा हूँ, और कर रही हूँ, right? Am I being honest about all my participant situation? Do the right people know what is going on? Should disclose it to the patient. Are my action in alignment of my personal values and those of the institute I represent? So these are the three integral part of the good clinical practice: ethics, values, and integrity. So I acknowledge all these persons, right? Thank you.
Yes, friends, as we don't have time now, I think whosoever is interested, they can have some interaction with madam. Before I finish, ma'am, it is very interesting to know always clinical research, good practices. Any good practice is required in any activity, agreed. But that too, when we are dealing with human beings, one has to be. A person should not die because of a drug reaction, but he can die because of a non-treatment or a no treatment available. That is the purpose, agreed. But in doing so, for the last 10 years, we have felt in India, at one time, 2010, clinical research is a hot destination for India, ultimate final destination. But it didn't happen. What was the basic lacuna that has happened? Clinical research has not taken forward in Indian scenario. That is the only question.
No, sir, I must say that things were different at the 2010.
Yeah.
But when it comes to under this DCGI now have a very serious note about that. If no clinical research should be done unethically, right? So they say there are regulatory authorities now. They are very strict about all these things. You have to register yourself. You have to submit your clinical data related with any studies. It should be registered.
Right.
And you have to follow the principles.
So more logistics have to be worked out. Because
That is there, and they have make it very simple nowadays. Each and everyone can regulate or submit their application.
So we all will thank madam for her excellent topic taking.
Very brilliant for you to give this talk because you are not much in the clinical research. But definitely when you are asking the question to Dr. Rajesh to how to translate it, I think that is the answer. It's very difficult to translate the research to the use, right? कब carcinoma में कब use करोगे? Cancer therapy में use होगा कि नहीं होगा stem cells. So all these ethical issues are there in pipeline when you come for or when you have translate your any research, whatever it is, right? So that's it. Thank you.
Thank you, ma'am. I request Dr. S.V. Dange, sir, and Dr. V. Adipalli to felicitate our speaker, Dr. Sneha Amwani. I request Dr. Vikram Chaudhary and Dr. S.S. Bhujbal to felicitate Chairperson and Co-Chairperson, Dr. S.V. Dange, Professor, Department of Pharmacology, Dr.DY Patil, Medical College, Hospital and Research Center. Here we come to an end to the technical session. We'll proceed with oral and poster presentation. Students with poster presentation, they can occupy their seats in the allotted classrooms, whereas this room will be occupied for oral presentations.
Next. This is GTI, that is glass twin impinger. This is official in Indian Pharmacopoeia and British Pharmacopoeia. Over here, you can see there is stage 1 and stage 2. This is in which we have to add metered dose inhaler, and accordingly we have to test with a definite flow. As per the guideline, the limit is for T1 it is 40%, for T2 is at least 20% should be there. So USP guideline says, IP and BP guideline says the total mass of the active substance should not be less than 75 and should not be more than 125% of the average delivered dose. This is the methodology for UDD. This instrument is officially, it is there in Copley Scientific UK. And this test is official in all of the pharmacopoeia, that is IP, BP and USP. Over here, you can see there is a DUSA tube attaching with the inhaler. This is critical flow controller having P1, P2, P3 valve timer, and this is high capacity pump. Over there, if we want to test uniformity of our delivered dose at BME studies, that is beginning, middle and end studies, we have to drive our inhaler through the DUSA tube, and this test is official in IP, BP and USP. For limits in IP and USP, it is out of 10 units. Means if I am testing my MDI inhaler, then MDI is having, say, let's 120 meter dose. So I have to study it in 3, 4, 5. Middle will be 60, 61, 62, and the end will be 118, 119, and 120. So according to that, the 9 out of 10 results should lie between 75 to 125%, and all should lie between 65 to 135%. If 2 or 3 fails, then again we have to test it on 20 more inhaler, means more units. Out of 30, 3 should be, not more than 3 should lie outside the limit of 75 to 135, 125, and all should be in the range of 65 to 135. Next. This is one of the most important tests as far as the NGI APSD, that is aerodynamic particle size distribution, is concerned. Over here, NGI is tested. This is also official instrument in BP and USP. Till IP 2022, it is not official. So over here, we have to check the aerodynamic particle size distribution of our metered dose inhaler, which is tested at 30 liter per minute. 30 liter per minute flow rate, and a timer will be about 30 seconds for each delivered dose. Then limit for the same test is not less than 75 to 125% of the average delivered dose, which is determined by DUSA apparatus in UDD test. So chromatographic conditions which we have used to analyze all these 3 tests were, that is sodium phosphate buffer we have taken in pH 3.2, and ACN in the combination of 65 to 135, 65% to 35%. Diluent we have taken as water and methanol 50-50. BDS hypersil C18 column with the ambient temperature and 220 wavelength with the flow of 1.5 ml and injection volume of 100 microliter. So over there we have found out all the stages of formoterol fumarate at 4.5 minutes, budesonide epimer B at 10, and epimer A at 12. Next. So here is the result and discussion. If you can see, the first test which we have performed is a fine particle dose by T1, T2 apparatus, that is glass twin impinger apparatus. The device T1 and T2 fraction, we have collected HPLC and 6.2 mcg per capsule, per actuation we have got for formoterol fumarate, and 381.4 mcg of budesonide we have got. In case of UDD, we have performed this BME studies, unit 3, 4, 5 as a beginning, 61, 62, 63 as a middle, 61, 62, 63, 64 as a middle, and 118, 119 and 120 as a end of this study. So minimum we have got is 77.9 and maximum is 100.4 for formoterol fumarate, and 80.2% and 107.2% for the budesonide. Next. For, thank you.
What is your conclusion? That is important.
Conclusion, I can say this research can be implemented for the emitted dose, FPF, FPD, and delivered dose identification for the routine stability and QC release testing for formoterol fumarate and budesonide MDI inhaler dosage form. Formoterol fumarate and budesonide is a corticosteroid, sir. They are utilized for the asthma and COPD diseases. Yes.
Very good.
Yes, sir.
Generally, when we use that method, there is a problem between the patient inhalation and dose actuation. So, do you study that particular problem in your study, and if you studied, how you overcome it?
Sir, for the patient, for the adult patient, it won't be a problem. For geriatric and pediatric patient, we do have.
That is inhalation problem might be to anybody, right?
Yes, sir.
And whenever we are going to achieve that particular peak flow, that inhalation, that particular amount of drug should be comes inside, and it is going to show that peak.
Yes.
That might be different in your body, that might be different in my body
Yes,
also.
sir. Yes, sir.
So you cannot say that it is not applicable to the adults one.
Yes, sir.
Do you study that particular problem? Because
Sir,
it is generally being covered by, that concept known as CAP. So do you study that CAP concept here?
Sir, actually we have studied with the spacer one. With the spacer. There are two types of spacers, sir. Open and a closed spacer. We have studied this test over the spacer. Also, we have studied...
Can you explain how the spacer would be helpful?
The spacer, if you can have that NGI diagram over there. Can you please? Sir, over here, with the help of this adapter, over here we have to put spacer. Spacer, open spacer or the valve actuated spacer, and we have to actuate this with the shaking of 5 seconds and 5 doses at a time at the interval of 30 seconds, sir. So we have done a trial and error, and we have achieved that method to obtain a spacer with the shaking of 30 seconds for 5 seconds actuation.
So you are not using any cap there, right? Only spacer you are going to use.
Yes, yes,
that spacer is generally going to act on the pressure, right? You want to say?
It will facilitate the that
inhalation.
Inhalation, and it will go directly to the mouth. It is like
site of action.
It facilitates propellant to deliver the drug faster, sir. That spacer.
You haven't done any type of clinical studies or preclinical studies?
No,
right?
sir. We are looking for in silico studies for the same, sir.
No, in silico studies you can do the prediction. But when you say that meter dose, that particular amount of drug is there, what that drug is continue giving the action or not?
Yes.
That can be confirmed only by using the preclinical studies, na? So you haven't done any preclinical approach.
No, sir. This is in vitro study.
This is a proof of concept.
Yes,
we can
yes,
say.
sir. Yes, sir.
Okay.
Yes.
Okay.
Thank you very much.
Next one.
Design and characterization of sustained release matrix tablet by using natural polymers. In this introduction, hydrophilic...
Skip. If you want to convey in 4 minutes, you should know what to do.
Yes, yes. Next, please. So, the aim of the present study is design and characterization of sustained release matrix tablet by using natural polymers. In this, objective of the study is first to formulate the sustained release matrix tablet, then evaluate these sustained release matrix tablet which is made by using the different polymers, then to study the effect of this natural mucilage on drug release, and fourth is to study the comparative evaluation of this mucilage on the drug release from the different tablets. Next please. In this methodology, first I have done isolation, extraction and purification of the natural mucilage. Then characterization of these natural polymers has been done for physicochemical, derived and macrobiological properties. Then characterization and pre-formulation study of drug material and other excipients has been done. Then tablet was prepared by wet granulation method. So for the granules, pre-compression study has been carried out, and then formulation and evaluation of the sustained release matrix tablet has been carried out. So this is the formulation design in which tamarind seed mucilage, linseed mucilage and fenugreek seed mucilage are used as a release retardant in different concentration, and 3 batches of each, for tamarind seed mucilage, 3 different batches with different concentration of the mucilage has been prepared, and same for the linseed and fenugreek seed mucilage. Next please. In the pre-formulation studies, in drug excipient interaction, FTIR and DSC was carried out, and there is no any significant change was observed, so it goes further for the compression. Then the various studies like physiochemical, derived and macrobiological properties of the mucilages were studied, where we studied the bulk density, tap density, compressibility index, Hodgkin's ratio, angle of repose. All these are the derived properties, and then swelling index, water retention, loss on drying, pH, melting point and practical yield were tested. Next please. In this result and discussion, for the tablet formulation, wet granulation method was taken, and with wet granulation method 6 mm single rotary punch tableting machine was used, and tablets were prepared. After the compression of the tablet, post compression parameters were tested like hardness, friability, thickness, diameter and drug content. Along with that, swelling as well as erosion study also carried out. In case of swelling study, it was observed that swelling was both in radial as well as in the axial direction, and here the swelling index of the natural mucilages are in increasing order. Are for tamarind seed mucilage, swelling is highest, then it is for fenugreek seed mucilage, and least for the linseed mucilage. And in erosion study, it's completely vice versa, that is erosion is maximum for the tablet containing linseed mucilage, then optimum for the fenugreek seed mucilage containing tablets, and least for the tamarind seed mucilage containing tablet. And erosion study confirms that the drug release was by diffusion from the tablet core to the surface, and the presence of both pores and gel structure on the tablet surface indicates the involvement of both erosion as well as diffusion mechanism for the drug release. Next please. Then in vitro dissolution profile of salbutamol sulfate tablet has been done, and in these 3 different batches were considered as an optimized batch from each of the category, as it releases maximum amount of drug in 12 hours, and among these FL1, the middle one which contains the linseed mucilage, is considered as an optimized batch as it releases 91.30% of the drug in 12 hours. Next please.
Your time is over.
It's next is only conclusion.
Yeah.
Yes. Next please. So from the study we can conclude that this linseed mucilage can be a better substitute to other expensive synthetic sustained release additives.
Any such product is there in the market now?
No sir.
So it's you have used which tablet drug? Salbutamol.
Yes, salbutamol sulfate.
There is no such marketed.
Marketed drug is for salbutamol, but it's with synthetic polymers, sir.
But not with.
Not with natural polymers. So here we are using tamarind seed mucilage, linseed mucilage, and fenugreek seed mucilage.
And you conclude as it is, linseed is better.
Yes, because in minimum amount, that is only 20 mg is required for 150 mg of tablet, and in least amount of the mucilage, it releases the maximum amount of drug, that is 91.30% in 12 hours. That's why. because the synthetic are like they are costly, they have some side effect, but in case of this natural, these are easily available. As sir, natural polymers, as these are easily available, they are biodegradable. No, sir. Sir, the advantages are like they are means as you said, it's easily available first, and they are biodegradable, easily degrade in the body. They have no side.
Difference in the release rate
Yes,
because
sir.
of that diffusal
Diffusion. Yes,
right?
yes.
What I know. So generally, when we use that matrix tablet, the diffusal rate is decreases. That is a major disadvantage of the matrix tablet. Can natural polymers can overcome that particular release rate problem?
Sir, the release rate is controlled by these natural polymers, and they releases the drug by erosion as well as diffusion mechanism.
No, I'm not asking that. See, release rate is the main problem with the matrix tablet. That is a major disadvantage what I know about the matrix tablet.
Yes.
So do these natural polymers can overcome that? Do you have some study that this release rate problem is totally being overcome? Say, when matrix tablet are there, when polymers are there, drug has to release. So you do the release study.
Yes,
but
sir.
the release rate problem is associated with the matrix one. So how do you study that particular thing?
No, sir.
No. So that is a major punch what you can show. And
Okay.
when we say that design, so the design word means that ki something is not there and you design something new. So there should be a comparative study between the synthetic polymer and natural polymers. The synthetic polymer are having these problems, which cannot be observed or which.
Learning is never cumulative. It is a movement of knowing which has no beginning and no end. Respected Dr. Sohan Chitlange, CEO, Dr.DY Patil Unitech Society, Principal, DPU Pharmacy, and convener of the conference. Dr. Vikram Chaudhary, Founder and Director, Operant Pharmacy Federation. Dr. Santosh Bhujbal, Vice Principal, GPO Pharmacy and co-convener. Dr. V. Adepalli, Research Director, HODs, teachers, and dear delegates. A very good evening to all. I welcome you all for the valedictory function of International Conference Pharmanecia 3.E on the theme Emerging Trends in Pharmaceutical Research, organized by Dr.DY Patil Institute of Pharmaceutical Sciences and Research, Pimpri, Pune, and Dr.DY Patil Medical College, Hospital and Research Center, Pimpri, Pune, and hosted by Operant Pharmacy Federation. Since morning, we have interacted and learned from various renowned speakers and then had a brainstorming session with the evaluator while discussing our research work. A day filled with learning. Now I request Dr. Rakesh Mishra, Associate Professor and Co-Convener, DPU Pharmacy, to give concluding remark of the conference. Please, sir.
Very good evening to all. I am very much pleased to give the concluding remark of this one-day conducted event on conference which is on emerging trends in pharmaceutical research. DPU Pharmacy is continuously engaged in organizing various activities to make sure that we are adhering to the most recent best practices, complying with all the requirements, addressing the future need of students, and exploring young budding pharmacists. As we all are aware that the field of healthcare research is constantly evolving with new technologies and approaches emerging all the time. This one-day conference is organized considering a broad interdisciplinary audience of academic and industrial researchers actively engaged in basic and applied research practice related to pharmaceutical sciences and medical research. On this line, DPU Pharmacy, in association with DPU Medical College, organized this one-day event where most prominent research persons from pharmaceutical industry and medical research background were invited to provide unique scientific informations and enriching experiences. We are very much fortunate that in collaboration of Operant Pharmacy Federation, we got the chance to organize such conference, as it is rarely observed that pharmacy and medical people come together to organize such conference aiming healthcare research. And because of this uniqueness, earlier in the last week of Jan, we have circulated the registration link for this conference, and within a short span of time, we got a huge response. In this conference, delegates from nearly 27 pharma and medical institutions across the India has participated. The preparation for organizing this conference under Pharmanecia 3.E was started from last year September month only, when DPO Pharmacy in association with Operant Pharmacy Federation has celebrated virtual 6-day NPW International eTech Fest. The winner and runner-ups of organized different events and competitions were awarded today with the cash prizes. Organizing committee of this international conference has worked hard to bring together most prominent experts to share their insightful experiences with us. In morning half, the keynote session was delivered by Dr. Anthony Crestoso, Advisor, Africure Pharma, Mumbai. Sir has highlighted the different horizons and scope of pharma research, near future of Indian pharma, demand of data analytics, information technology in pharma sector, status of medical coding, clinical research and business development in India. In the interactive session, Sir has also discussed with students and delegates regarding the skill sets required, need of hard work, regular updation of knowledge, and need to learn the basics. Sir has also appreciated the students by giving them the prizes. Post-lunch, 2 sessions was conducted. Professor Dr. Rajesh Ramasamy, Head of Department of Pathology, Faculty of Medicine, Health Sciences, Teaching Hospital, University Putra, Malaysia. Sir has given his insights on the use of phytochemicals in exploiting stem cells for effective therapeutical purposes. Plant-based isolates, compounds, and extracts are fundamental in drug discovery and therapies. Stem cells are the primary component of regenerative medicine that has been investigated for diseases that were considered terminal. The vital aspects of stem cells are self-renewal and multipotential differentiation, which make them beneficial for various degenerative diseases. Sir has also highlighted that phytochemicals, polyphytochemicals, crude or semi-purified herbal extracts and polyherbs have shown their adverse free activities via several signaling pathways in enhancing the physiological culture of stem cells. By carefully assessing the role of phytochemicals on normal and cancer stem cell, it could open a new way of fostering health and adding value to existing therapeutical phytochemicals. Dr. Sneha Ambani, ma'am, MBBS MD Professor and Head Pharmacology, AIMS Jodhpur. Her session contained the information on good clinical practices and guidelines for biomedical research. Madam has highlighted the goal of GCP, which is to protect safety, rights, and welfare of humans participating in research, to assure the quality, reliability, and integrity of data collected, to provide standards and guidelines for the conduct of clinical research. Madam also shared with us the ICMR ethical principles of GCP, which includes benefit risk assessment, informed consent, justice, conflict of interest, vulnerable populations, post-research assess, and benefit sharing. In this conference, oral and e-posters was also scheduled to provide a platform to researchers, innovators to share their research work with the experts, and also they have got the chance to interact with the experts, and the experts have given them the inputs on the research area on which they are working. Among 198 received abstracts, 20 oral and 80 e-posters were shortlisted for the presentations. Thanks to the scientific committee and evaluators for being a part of this process. Thanks to the chair, co-chairperson who are involved in the smooth conduct of the sessions. Thanks to the delegates and oral e-poster presenters for your active participation. Special thanks to our management for providing us such facility, and special thanks to our principal, Dr. Sohan Chitlange sir, for always giving us the chance, and he always provides us the different opportunities and always positively, sir, pushes us to involve in many such activities. Thanks to each and every member of organizing committee for their untiring efforts. The collective efforts of all have made this conference a great success. Hoping this conference has provided us the chance for networking, engagement, and knowledge transfer. Would like to end my conclusion with a quote quoted by Krishnamurti that learning is a continuous journey, not the destination. Thank you so much.
Thank you, sir. Success of any event is measured by the feedback from the participants. Good feedback is the key for improvement. Now I request Ms. Apurva Wankhede, MIT College of Pharmacy, Pune, to share her feedback. You can come here, yes.
Thank you, ma'am. Good evening, everyone. So, yes, we all had a great brainstorming day today. It's never out of trend to learn about emerging trends in pharmaceutical researches. So, yes, today we got to get in with the emerging trends that are going on in pharmaceutical sciences. The session began with the keynote speaker, Dr. Anthony, and as it was not expected, it went really interactive. Like we all had made it in our mind that it will be a boring lecture sort of and we'll have to listen and it will get bored, but nothing like that happened. And the part that I appreciate the most is we got prizes for asking questions and our questions got answered. So yeah, I appreciate that part. Then we got to know about inducible pluripotent stem cells by Dr. Rajesh. It was new to me, so yes, it made me think about what more can be done in the same aspect. Then Dr. Sneha, she told us about good clinical practices. Me being from a pharmacology background, I guess that will help me a lot in my future endeavors. So yeah, I thank DPU, Pharmanecia 3.E, and Operant Pharmacy Federation for organizing such a successful international conference. I look forward to more such conferences and I have high hopes from DPU for arranging such more sessions. Thank you so much, DPU.
Thank you, Apurva. Now I request Ms. Alfia Biradar, Modern College of Pharmacy, Nigri, Pune, to share her views.
Good evening, everyone. First of all, I'm glad that I got the opportunity to attend this international conference. And our highly experienced and highly talented guests gave us a lot of information regarding the emerging trends in pharmaceutical research. It was really an interesting session. And I would also like to thank a lot the organizing and the hosting committee for organizing such a good event, which was really helpful for us. The e-poster and the oral presentation competitions were also beneficial for us to know the knowledge about what is going, like what research is going at the academic level. So thank you so much. Thank you.
Thank you, Alfia. Now I request Ms. Surbhi Jarare, DPU Pharmacy, to share her views.
Good evening, everyone. As every day you have opportunity to learn and experience something new and someone new. Seize that opportunity, learn and experience everything you can and use it to change the world. Today, we all attended the conference arranged by DPU Pharmacy, that is Pharmanecia 3.E. I'm very much glad to share my experience. Today's day started with very great and energetic interactive session with Dr. Anthony Christo sir. Then there was a next interactive session, which is we all attended by Dr. Rajesh Ramasamy. Individually, it helps me a lot because I am doing M-Pharm project on same thing, stem cells. So there are very much keynotes and key points to understand me more about the stem cells. Next, the topic was good clinical practices, which was taken by Dr. Sneha Ambawani ma'am. As the good clinical practices is the general topic which we studied in B-Pharm, M-Pharm in every phase. But ma'am gives more insight about that. And today's conference was not only arranged sessions, but also arranged e-poster and oral presentations. I think all participants must enjoy that process also. We all get mesmerized with knowledge get shared in this conference. Lastly, I would like to thank DPU Pharmacy and also DPU Medical College and Operant Federation for arranging this good session. Thank you.
Thank you. Now it's time for which all are eagerly waiting. Time to announce winners of oral and poster presentation. Winners are willing to go longer, work harder, and give more than anyone else. I request all the dignitaries to give away the prizes. We will be giving prizes for oral presentation first. I request Dr. Sohan Chitlange, co-convener, to give away the prizes. Runner-up position is backed by Ms. Sakshi Sonaune, Dr.DY Patil Institute of Pharmaceutical Sciences and Research, Pimpri, Pune. First prize goes to Ms. Priyanka Karpe, Vishwakarma University of Pharmacy, Vishwakarma University, Pune. I request Dr. Vikram Chaudhary, sir, to give away the prizes for e-posters. Second runner-up position is backed by Ms. Dipti Durat, School of Pharmacy, MIT World Peace University. First runner-up position goes to Ms. Payal Karche, Dr.DY Patil Institute of Pharmaceutical Sciences and Research, Pimpri, Pune. And first position is grabbed by Ms. Pooja Deshmane, PhD scholar, DPU Pharmacy. Congratulations to all winners and all the very best to everyone for their future. For today's conference, we had around 200 posters and those were evaluated by the team of experts from DPU Pharmacy. It's time to appreciate their efforts. I request all the evaluators to accept the token of appreciation. Dr. Asha Thomas, Head, Pharm Chemistry and PQA and R&D Coordinator. Please, ma'am. Dr. Lata Kotapalli, Head Academic Monitoring, DPU Pharmacy. Dr. Sanjeevni Deshkar, Head Department of Pharmaceutics. Dr. Vrushali Undale, Head, Department of Pharmacology. Sorry, Vaishali Undale. Dr. Ritesh Bole, Associate Head, Department of Pharm Chem and PQA. Dr. Tanaji Nangude, Training Placement Officer. Dr. Maruti Shelar, Head, Diploma in Pharmacy. Dr. Jayashree Mahaure, Associate Head, Academic Affairs. And Dr. Vinita Patole, Assistant Professor, DPU Pharmacy. I request Dr. Vikram Chaudhary sir to felicitate co-convener of the conference, Dr. Santosh Bhujbal, Vice Principal, DPU Pharmacy. Dr. Rakesh Mishra, Associate Head, Department of Pharmaceutics. We would also felicitate the organizing committee in charges and the members of their team for their tireless efforts in coordinating the event. I request the in charges to please accept the token of appreciation on behalf of the team. I request Dr. Ravindra Bawale sir. Poster evaluation team can join, sir. Poster evaluation team members, students and teachers can join them. First year MPharm students have coordinated the event. Dr. Harshad Kapre and team for oral presentation. Students, speed up. Mrs. Rachna Bimanwar and team, inauguration and felicitation team. Mr. Subhas Chate and team, prize distribution. Dr. Karishma Rathi and team, registration. हाँ, सर ठीक है मैं खुद ही देखूँगी। Miss Roshni Pagar and team, technical team. Dr. Sejal Gandhi for anchoring. The event.
Dr. Sejal Gandhi ma'am for the anchoring. All of you clap.
Thank you all. Thank you. Now I request Dr. Santosh Bhujbal, Vice Principal, GPU Pharmacy, to propose formal vote of thanks.
A very warm good evening to everyone present here. I'm honored to spell out the word of thanks for today's international conference. On behalf of the organizing committee of Pharmanecia 3.E, I wish to express our humble gratitude to our Honorable Chairman, Dr. P.D. Patil sir, for providing excellent facilities and resources towards the conduct of this conference. I wish to express my profuse thanks to our Honorable Secretary, Dr. Somnath Patil sir, for his continuous motivation and encouragement, which has been instrumental to all of us to work for this conference. I acknowledge the valuable presence of today's chief guest, Dr. Rajesh Ramasamy sir, guest of honor, Dr. Anthony Christo sir, Dr. Sneha Ambavani madam, for their excellent scientific deliberation. I thank all of them for gracefully accepting our invitation and being with us. I am confident their voluminous knowledge and experience which was shared will definitely guide all the participants in their future endeavors. My heartfelt thanks are due to Mr. Vikram Chaudhary, founder, Operant Pharmacy Federation, for being associated with us and for his untiring efforts throughout this conduct of the event. I would like to extend my deepest appreciation to Dr. Jitendra Bhavakar sir, convener and Dean, Dr.DY Medical College Hospital and Research Center, for huge support extended during this event. I wish to express my heartfelt thanks to Dr. S.S. Chitlange sir, convener, principal DPU Pharmacy, for his incredible leadership, timely and proper advice for organizing this conference, which has been very helpful to work for this event. I now extend my heartfelt gratefulness to all our chairperson and co-chairpersons and evaluators for their time and support. I place on record the goodness of all the delegates for their active involvement, which has been the key towards the success of this event. Thanks a lot once again. My special thanks to Dr. Rakesh Mishra, co-convener, who was with me for all the time, and I sincerely appreciate his support. I would be failing my duties if I didn't acknowledge the untiring efforts and dedication of teaching and non-teaching staff members who has helped to organize this event. I now extend my special appreciation to all our PG students for their excellent cooperation. Thank you for being the key players in our success story. Before concluding, let me express my sincere gratitude to all the delegates who had participated in this event and to the technical support team for their uninterrupted audio-visual facilities. Finally, with much respect and reverence, I thank everyone present here. Thank you.
Now I conclude the International Conference Pharmanecia 3.E on the theme Emerging Trends in Pharmaceutical Research. I request everyone to please rise for National Anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. Thank you all. Everyone, please be